My name is Simona Glasberg. I'm from Hadassah Medical Center in Jerusalem, and I am the co-chair of the Rare Disease Committee of the European Society of Endocrinology, together with Professor Alberto Pereira from Amsterdam University Medical Center. I am really delighted to welcome all of you to this first in a series of joint rare disease webinars, which are the result of the close collaboration between the European Society of Endocrinology, the Endo-ERN, and the European Society for Pediatric Endocrinology, today focusing on essential insights for the transition from pediatric to adulthood care in rare pituitary disorders. I would like now to hand over the virtual microphone to Professor Alberto Pereira to introduce our distinguished faculty, and I really hope that you will enjoy this afternoon session. Thank you. Alberto, please.
So, dear colleagues, dear friends, thank you, Simona, for the so kind introduction. It's really a big pleasure and privilege to co-chair this committee together with you, so that the synergy is so evident. So as the coordinator of Endo-ERN, I have the pleasure to co-chair the specific and distinct committee with Professor Simona Glasberg. And today it's, from a historical perspective, a pivotal time, because for the first time, both societies and Endo-ERN decided to also co-develop a specific webinar program directed towards not only the pediatric endocrine perspective, but also the adult endocrine perspective, and last but not least, the very important patient and parent perspective. And having said that, we were able to develop a very distinguished faculty that represents all of these perspectives. So first of all, Professor Violeta Jotova, she's a professor of pediatric endocrinology from Varna University in Bulgaria. And Violeta is also the chair of the educational work program of Endo-ERN. Next, Professor Evangelia Sharmandari, she is the pediatric chair of Endo-ERN of the main thematic disease group of hypothalamic and pituitary condition. Thank you also so much, Evangelia, for joining us this afternoon. Then we have the adult expert chair of the main thematic disease group of hypothalamic and pituitary, which is Professor Nienke Biermas. She is not only co-chairing the Endo-ERN main thematic group, but she's also a professor of endocrinology in specific and pituitary conditions, Leiden University Medical Center in the Netherlands. And not last, but pre-final, our co-chair of the main thematic disease group representing the patient and parent perspective, Mrs. Diana Vitale from Italy. It's really a great pleasure also to have you here, Diana, to share with us your patient and specifically parent perspective. And it's also a big pleasure also to host you as a patient layman expert perspective of the main thematic disease group of pituitary of Endo-ERN, also from the birth already of our network. And last but not least, Dr. Savi Shishkov, also from Varna, Bulgaria, of whom we had the pleasure to host as one of the first clinical fellows in our Endo-ERN exchange program. Well, having said that, I would like to now provide the floor to Professor Nienke Biermas to introduce and to start the program. Thank you so much.
Thank you so much, Alberto and Simona. And yes, well, I think we have all had some small introduction. I'm very pleased that we can host this webinar today. I think it's a great initiative from the joint venture between ESE and Endo-ERN that can take place. I'm also very happy that the Endo-ERN is now in such state of development that we are really having new opportunities to do patient-centered activities. So not clear research, not focused, monodisciplinary issues, but this is a true multidisciplinary thing. Thinking about transition, it's very important for patients. We will listen to the story of Diana later on about her and her daughter and their journey. And transition is a topic that is of particular importance, of course, for all chronic disease patients, all endocrine patients, but also for pituitary patients. And probably you might know me as the adult chair of the Endo-ERN, which is of course a structure of 8 main thematic groups, and pituitary is one, and all were formed by an adult chair and a pediatric chair and patients representatives, and in our case that is Johan de Graaf and Diana Vitale, and Diana is here today. And I would like to give the floor to Evangelia Chamandari, who is the relatively new pediatric chair, for short introduction. And maybe you can already give some ideas on your thoughts about transition before we start the official program.
Yes, thank you very much, Janke. Dear colleagues, welcome to our joint webinar. We truly hope that you will enjoy it and you will find it useful. We all know that children and adolescents with pituitary or hypothalamic disease or any other rare endocrine disorder represent a diagnostic and management challenge for all of us as healthcare providers. And the transition to adult care is very important and needs to be well planned, well structured, and well implemented in a way that provides a continuum of care from childhood through adolescence into adulthood. And this seminar is all about securing the basis for providing a comprehensive and multidisciplinary transition care into adulthood. Thank you very much for joining us.
Yes, then go back to the program, and I would like to mention the audience that in the Q&A box it's possible to pose your questions. We will address the questions at the end of the webinar. And we will also make use of a Mentimeter to get a flavor of what is living in society about transitions, the unmet needs, the ideas that are around. And then we can have discussion. So we really hope to have a lively discussion at the end. I want to introduce Diana Vitale. With her patient story about things encountered during transition, and it's her personal story, and she's a distinguished part of our main thematic group. So please, Diana.
Thank you, Nyanke, and thank you to everybody, and I'm very honored to be here with such a very, very important expertise in pituitary diseases. So it's a kind of a dream happening in my story as a patient's expert, as a patient's representative. But I'm also very amazed in a way that we are going on this topic, which is a very important topic for the patients, but not so mentioned, never. So, of course, when a patient talks about his experience, it is quite difficult, and maybe my talk is too long. So I will try to be short. a little bit shorter. And so we can go on with the slides. Thank you. So I put these two photos of Carolina, my daughter, because they are in a somehow representative of the passage from children to adult. Next slide, please. And so my daughter, Carolina, born with a rare pituitary condition, now is 34 years old. And I am happy to say that she is in excellent care in a children's hospital. Well, sometimes it is embarrassing. For example, in the waiting room during the hospitals, when even for the nurses, it is difficult to frame the type of communicative relationship with us. I am still mom and she's the baby. But these are jokes. In a complex conditions like Carolina's, who has SOD+, a highly specialized care is absolutely necessary. Next slide, please. It seems a paradox. If a specialized care is needed, why would an adult patient prefer a children's hospital? But the answer is not that simple, because health and social care centers have been established around the child, structured to accommodate the needs of the child with complex illness and disability and his or her family. These centers somehow manage to meet the different needs for health, therapy, rehabilitation, neuropsychological aspects, listening, information, and support with a multidisciplinary approach. Next slide, please. Although not a true health and social integration facility, the pediatric center is an important reference point that allows for real communication and a trusting relationship and an acceptable quality of life for the whole family. The situation for the adult care center is completely different. But this is just one of the aspects that make transferring from a pediatric hospital to an adult hospital very difficult. But there are also other aspects related to the high medical specialization required for some rare congenital endocrine diseases. Next slide. In our case, physicians, pediatric endocrinologists with high expertise in a specific disease, SOD, care for the patients, my daughter, regardless of age, thus ensuring the best possible care. I could say that they are Carol's medical experts. Next slide, please. When the first visit to this children's hospital was made, Carolina was already an adult. Another paradox. And this happened by a chance because I was desperately searching for a solution for her epilepsy. And then I discovered in the same hospital a team of dedicated doctors for a rare endocrine condition. So I have been trying all the adult care center option that I knew. And so that was my best option for taking care of her health. Next slides, please. And some of this you encountered in our experience of the so-called transition. Lack of real transition path and no information, sense of isolation, helplessness, despair and fear, feeling guilty and depressed for me, continuous search for a good center, difficulty in communication with other medical specialists previously coordinated by the pediatric center, difficulty in having the treatment plan, many months completely without growth hormone, appointment at outpatients clinic, consider the months for the waiting times. So I was waiting for months to go to these meetings, appointment, and then they were not worthy and maybe dangerous. We had emergency and hospitalization, many days of illness, not knowing what to do. It was impossible for me to work, and it was impossible for me to take care of the other children too. And then there was a waterfall effect on the quality of life itself. Next slide. So since Carolina is born in '88, the path for Carolina diagnosis and treatment has been always difficult, but the period of transition was most complicated, with very serious repercussions on the medical outcomes and quality of life, not only of Carolina and her parents, but also of her two brothers and two sisters living together. Above all, there is a lack of instruction for use from the very beginning. There is no guidance, no information, no explanation of the paths a patients is following, what will happen as he or she grows up, what step will need to be taken when he or she becomes an adult. Next slide, please. And if you say the word transition, even to a parent or to an affected person, they will not understand what you mean. So at the present time, it cannot be said that there is one method or choice that is better than another or sure to be effective. But for each patient, the path is different and highly variable. There is flexible and customized approach. The referring physician is a fulcrum around which all management of the medical condition and the patient's quality of life revolves. Next slide. The process is generally like this. So everything is at the discretion of the medical expert. And this is also a good point because it is a kind of personalized care. Usually, the transfer to adult care leads to worsening health conditions. And very often, the patient chooses to go privately, mainly to facilitate communication and visit arrangement. And I didn't have any report of multidisciplinary meetings between adults and pediatricians. Next slide, please. The word transition should mean a structured process of accompanying the transfer not only to a different healthcare center specialized for adult care, but to a different approach to the management of the disease itself, which in the case of disabling and complex chronic diseases coincides with the quality of life itself. In my experience, this word is emptied of this deep meaning by indicating a mere bureaucratic process. Becoming a leading actor in one's own care process increases self-awareness, promotes autonomy and independence, facilitates management and living with the disease. This certainly helps in defining symptoms, cessation, responses to medication. In fact, in pituitary diseases, an issue often reported by patients and relatives is a difficulty in recognizing and being aware of one condition and thus intervening early. Next slide, please. To this day, I do not know when my daughter became an adult and whether she ever did. Some of her characteristics make the achievement of autonomy difficult, but is it not the same for the majority of people with pituitary diseases? How important is it for a person's autonomy and growth to take care of themselves and to be able to cope, to treat their illness independently? What does addressing a patient in person or a patient's parent mean for a physician? How much can empowerment of the young patients affect adherence to treatment in pituitary diseases? How does an adult person, even a partially autonomous person, feel about doctors always speaking in the third person? And what does this mean for the doctor himself? So the transition directly affects medical outcomes and the quality of life, and it is directly connected to the person's actual transition to adult life. Can we solve this paradox? So I was trying to be a kind of provoking something, but my experience as the president of a patients organization says that during transition, most patients have a lot of problems. And very common, they went in a period of not having a properly healthcare. Then they try and they found a solution. So thank you very much. And I hope we will solve this paradox.
Thank you, Diana, for this most beautiful presentation, very open and very instructive for us. It only shows to us that we are growing together with the patient's problems and with prolongation and improve of their lives and improvement of the quality of life. Some of these achievements go well with the, sorry, I have to share my screen, just a second. Go together well with the achievements that we have in the knowledge generation and sharing. And it's my pleasure today to present with the from the name of the whole group with Professor Shalin Gentil and our patient representatives in the work package 1 of the network, Petra Brugman and Manuela Brosamle. The ERN clinical exchange program is universal for all ERNs, and it started within the most severe COVID times in March 2021. So it really didn't start on time, but it is meant to stimulate knowledge sharing, clinical capacities and organization, and to improve expert clinical care. Either hosting health professionals or visiting another healthcare provider with a specific predefined aims between the fellow and the host. It can lead to on-site teaching of staff, sharing of standard operating procedures, and also seeing patients in and out patients together, which is important for both sides. More specific aims are encouraging the development and implementation of value-based healthcare, the way forward to which Diana was leading us. Investing in outcome measurements and aligning in registries in order to be comparable between ourselves, for the professionalism of the multi-care teams and its integration in the specific care pathways as much as possible at different vicinities and different hospitals. And of course, stimulating the development and implementation of clearly defined transition from childhood to adulthood, as Diana says, to fill in this word with more meaning than just an administrative term. So the first exchange happened in October 2021. And in this newsletter, you can see the happy face of the first fellow, Dr. Savish Shishkov from our hospital, who is an adult endocrinologist and who wanted to study specifically the transition pathways in the tertiary center under the guidance of Professor Birmas and Professor Pereira. Still, we have possibilities for other fellows to visit other centers. The host centers and the applicants should be part of the Endo-ERN. and should connect to the Leiden office management. We have shown the email for those who are interested. And you should know that we still have 33 remaining packages. One package is 1 week. And so far, the maximum possible duration is between 4 and 6 weeks, but mostly 4 weeks. Of course, it could be just 1 week. And you can still apply. The packages will be distributed on the principle first come, first serve basis until the end of December 2022. And the last date on which you can start the package is end of January 2023. So with this, I would like to give the floor to Dr. Shishkov, the first fellow, and to invite everybody to apply because it's a really, really great opportunity for all of us. Please, Savi.
Thank you for your introduction. After this impressive story that we heard from Diana about her daughter, I hope I can give you some insight into the healthcare perspective of transition and maybe some insight into what the landscape of transition is across Europe. So first, I would like to say that this presentation wouldn't exist if it wasn't that clinical exchange program when last year me and Dr. Duchulo were hosted in Leiden in the Netherlands for 1 month. So this is actually the result of multi-center collaboration. So we got a very good idea what actually transition is from the story of Diana and the introduction from the chairs of this session. But to start with a definition, usually definitions of transition differ and they represent many different perspectives. Sometimes they are more descriptive in nature, but the more common definitions include that this is the process of moving a patient from a child-oriented style of care to an adult-oriented style of care. Or otherwise defined, this is the purposeful and planned movement of adolescent and emerging adults. So transition involves is not just the moving of patient from one setting to another. This happens in an age period when there are psychological, physiological changes and also changes in legal perspective. So a lot is known about this period, what changes occur in the young adult, and it is a complex period. That's why a lot of time and care is invested both by primary healthcare providers and specialized healthcare providers in order to ensure the best outcomes for the patients and to give them the ability to manage their own conditions. So in the course of the process, 2 questions are key. One of them is how to encourage the young adult to take responsibility for his own health. And the second is how to organize care in such a way that anything achieved in pediatric age is not lost. Last but not least, I would like to make the distinction between transfer and transition. As Diana said, the transfer should not be just a bureaucratic hurdle. It should not be just a problem, but it should be the culmination of all efforts done and all achievements achieved during the process of transition. So they're not synonyms. So obviously, not all issues around transition are resolved. Actually, there are a lot of pending issues. For this reason, it was decided to initiate a survey aimed at healthcare providers from MTG 6 centers across Europe. The survey consisted of 31 questions. Some of them were open answered, some of them were close answered. The questions, most of them were made anew, but some were borrowed from problems already outlined in studies. The survey consisted of 2 parts. The first one was about general aspects about physicians' practice, and the second part was about their particular transition of care aspects. Another goal of this survey was not only to summarize best practices, but start working towards alignment of these efforts on European level. At the time of the survey, Endo-ERN consisted of 78 reference centers. Among them, 43 were endorsed for pituitary expertise, both nationally and internationally. From those 43 centers, we got responses from 30 centers, and those 30 centers and their distribution is shown on the map. That meant we had 70% response rate. We had 70% response rate. From those 30 reference centers, we got 46 answers from 46 doctors. 2/3 of them were adult endocrinologists, and 1/3 of them were pediatric endocrinologists. One of the most difficult challenges to overcome was, as I said, the different definitions of transition. Therefore, we asked our participants to provide a definition of transition in their opinion. Most often these definitions, despite being different both in length and in content, they included the fact that it is about transfer from pediatric to adult settings. They also acknowledged the need for planning and the need for joint efforts, combined work between adult and pediatric staff. Two of the rest represented point of views was that transition may be an administrative burden, or it can also help build up physicians' expertise. These two viewpoints, despite being very few represented, these answers were received by only one participant each. They may represent important barriers towards implementing successful transition protocols and process. For sure, referring a patient from one department to another involves bureaucracy. Simultaneously, expertise building is an issue for adult endocrinologists that have to deal with conditions that are usually in the realm of pediatrics, and they're not accustomed to that. Well, transition of care, maybe not surprisingly, the practices are not the same everywhere. Transition coverage is not 100%. All patients were transitioned by 65% of all responding doctors, while 30% of all doctors do not transition all their patients, but most of them. This last gray bar represents one of the centers in which there is no transition of care. In that center, endocrinologists with expertise in specific conditions, in specific disease, take care of patients both in their adult years and also while they're younger than 18 years old. This way of managing patients avoids some of the inconveniences associated with the transition of care model, like the fragmentation of services or the need for the patient to meet a new healthcare team and adjust to them. This model of no transition has parallel in diabetes care, but it has not been compared directly to the transition of care model yet. But still, based on our current knowledge and our current medical practice, it might be preferable that the transition of care model is better for the patient because it tailors the expertise of the pediatrician and the expertise of the adult endocrinologist to the respective patient. One of the major findings of our survey was that written transition of care protocols or guidance is present in the minority of centers. So in 9% of the reference centers involved in this survey was a written guidance present. But still there is light in the tunnel because 20% of all our respondents, around 9 responses out of 46, 9 doctors stated that transition of protocol is being developed in their hospitals. So then we asked our participants what actually determines this time period we call transition period. The beginning of transition, as you see from the graph in blue, is most often associated with age. 42 out of 46 respondents stated that. Less important, but still considered by the physicians, are the personal clinical judgment, the skills and knowledge of the patients, the medical outcomes, and also the wish of the patient. The end of the transition period is a different matter though. As you can see from the graph, the role of age diminishes for the end of transition, but the clinical judgment of the physicians, the knowledge of the patient, and the medical outcomes gain more weight compared to the start of the process. This shows that chronological age is important for the start, but achievements achieved by the treatment, by the doctors, and personal development milestones for the patient himself are more important for the end of transition period. We also asked what is the usual age at start. Most often physicians initiate the transition process around in the time period between 16 and 18 years old. Less common was the time period 14 to 16 years old. And only one participant stated that this process begins in age younger than 14 years. In contrary to that, some transition guidance that has already been developed, like GOT transition or Ready, Steady, Go, recommend that the first small pieces of information be provided to the patient when he is even younger than 14 years. Of course, there are a lot of practical aspects that were not covered by our survey because that was not the aim of it. But we can see a discrepancy between theoretical framework and practical application. This difference is very important because it needs further inquiry into that, because it may reveal, again, very important barriers towards implementing transition practices. The end of transition in orange is much more variable. As we saw, the age at end depends mostly on other factors, not only age. So how are decisions taken by the treating doctor during this period? First of all, decisions are taken in multidisciplinary teams. But the meetings of these teams, again, it's everything else, they're not uniform. In most centers, they are regular. But in the rest, around 1/3 of all centers, these meetings are irregular. They occur only for certain cases. Sometimes they are only for difficult cases. The core of this transition process, as already mentioned, is the multidisciplinary team. It usually involves a nurse, psychologist, gynecologist, and geneticist, less often a social worker. The need for this multidisciplinary team reflects the complex nature of pituitary conditions. In some hospitals, other medical specialists were involved, depending, of course, on the pathology treated there. But in order to coordinate all these efforts, transition readiness is the key. And this is defined as the process of building the capacity of the adolescents and those who are involved in his or her medical care in order to prepare, enter, continue, and complete transition. According to our survey, this was assessed by the majority of physicians, but the way it was assessed was mostly based on subjective opinion, like informal consultation with a colleague, asking the parent, or talking to the patient alone. Of course, this is based on expert advice. It is highly personalized, but still it again shows the lack of written guidance and a kind of standard approach among reference centers. 3 of our respondents, all of them were adult endocrinologists, stated that they use validated tools like Transition Readiness Assessment Questionnaire, Ready, Steady, Go, both of which are generic questionnaires, and the only one that was specific for pituitary disease was the Endocrine Society Transition Readiness Assessment tool for patients with hypopituitarism in particular. So transition readiness is a very important subject. It is the basis on which some generic transition programs are built. Obviously, the question arises, why is a specific pituitary tool so rarely used? Again, this was not covered by our survey, but is an important matter that, again, needs further inquiry. The two generic tools mentioned can be used in a number of chronic conditions. By using a number of standardized questions, different problem areas can be identified, like knowledge of the disease or attitude towards the healthcare team, adherence to therapy, and so on. Based on this, certain interventions can be planned, problem areas can be identified, so that interventions may be most useful. In contrary to that, a specific pituitary specific or disease specific in general transition readiness assessment questionnaire involves more detailed questions, as you may see from these two pictures here, about the specific disease. In pituitary disease, for example, that would be questions about corticosteroid stress dosing, growth hormone prescription, dosing, puberty induction, and so on. Both of these approaches have their advantages and disadvantages. Obviously, the generic questionnaires can be used in a number of different chronic conditions, and that has the benefit of comparability. Also, that is possible because psychological issues in chronic disease are very often similar. On the other hand, pituitary-specific questionnaires have the benefit of tracking disease progression and giving more detailed measures of medical management. For example, in one of the reference centers that responded, the physician there stated that a protocol was under development, which involved a generic questionnaire combined with multidisciplinary team meetings, electronic reminders, and assessment of patient-reported outcomes. This is a kind of integrated approach that has been proven beneficial by some systematic reviews. However, the decision between generic, disease-specific, or a combination between both type of tools, which one is better, remains to be seen in future. As everything else, the practice about transfer is, again, not uniform among healthcare centers. In some cases, in some centers, the preparation is done in 1 or 2 combined visits. In some cases, there is just 1 combined visit. In some cases, the pediatric endocrinologist just makes an appointment with the adult endocrinologist. What is similar, though, is the documentation that is used in transfer. The health summary and the transfer plan are the 2 documents that are used in most of the centers. And the information contained is the comorbidities, past illnesses, current medication, adherence age, and so on. What is notable, though, is the fact that patient-reported outcomes are used in only 8.3% of all centers. Then we also asked our respondents if patient-reported outcomes are used. And again, as you can see, the prompts used among all doctors that took part in our survey is very similar to the distribution of our reference centers that do have transition protocol. Patient-reported outcomes are very important because they enable putting the patient perspective in the context of value. They can be utilized not only for every single patient, but they can also be used for in-hospital decision-making. But the problem is that the set of patient-reported and doctor-reported outcomes is not well defined for transition and is not well defined for pituitary transition as well. The last part of our survey was aimed at identifying unmet needs. In the form of Likert scale questions, we gave the opportunity to assess the need, the necessity of a number of statements. According to the doctors that took part in our survey, the collaboration between pediatricians and adult endocrinologists, the interventions to encourage self-management and adherence to therapy are most important. Based on these results, most of these are important, but the one mentioned are vital according to the participants. Respondents were also given the opportunity to point out, as in the form of open text, what they considered unmet needs in this field. Most common was pointed that a guidance is needed, also that should be done as a form of an EU-wide approach. Also, mapping needs is not accomplished. Sharing protocols is another thing that participants would like to see. And last but not least, defining what success of transition means. Defining success of transition is difficult both in transition in general and transition in pituitary disease in specific. To sum up, this is a general transition guideline where gradually in the time, in different ages, somewhere between 16 and 20 maybe, the child should grow into adult, take care of his own health, and gradually take on responsibilities as an adult. So based on our survey, some facts became evident. First, transition of care is commonplace. It's most often planned, and it's most often done in combined meetings. Second, transition of tools for transition readiness assessment are present, both generic and pituitary specific, but they're very rarely used. Also, transition of care guidance is lacking, but it is needed. Last but not least, method for assessing outcomes are not well defined. They need to be, and they need to include patient's perspective. So based on all these results, the following research agenda comes intuitively. First, identification of barriers and facilitators of transition should be identified. Like, for example, why are patients transition most often between 16 and 18 years old? Why are protocols not implemented, and so on? Outcomes, as mentioned, should be identified, both general and pituitary specifics. Also, we need to know the most appropriate ways to measure these outcomes. Most useful and most meaningful interventions should be identified. And the last thing, which is the end of a long process, is to develop a guidance. For this guidance, inter-center collaboration is key because, as we saw, practice varies greatly, and that cannot be done just by one hospital alone. So to sum up, the take-home points are that knowledge, organization, and perceived needs for transition are present. But structure and comparability in conduct and assessment is lacking among centers. There are no clear outcomes, in particular regarding pituitary disease. There are few pituitary specific tools, and they're very rarely used. At the end, I would like to thank all researchers, all my colleagues that helped for this to come true, because this is a multi-center collaboration, and to all respondents that took part in this survey and gave their valuable input. Thank you again for your attention.
Well, thank you so much. I think you really did well with presenting your thoughts and making also use of the opportunity to address, to request input from Endo-ERN centers, so centers throughout Europe, to ask their way of dealing, their strategy. And I think it's very interesting. As far as I can see, there are not real questions at the moment from the audience. So please, if you want to put question in the Q&A that we can discuss, that would be great. Violetta or Evangelia, Diana, do you want to add something after the presentation of Savi?
I also want to thank Savi and the whole group for the nice survey, first of all, and very meaningful results. And in fact, we already have one question in the Q&A box, and it's from Kirsten Davidze, which says many centers indicate that they facilitate transition, but if this stops at the age of 18, is the age at end slide suggest, as the age at end slide suggests, do you think that can call this transition, or do you consider this more a transfer? I think Savi should answer this, because I didn't get the impression that we put an end at the age of 18, but Savi, would you please answer the colleague?
Yes, sure. Thank you for the question. As we saw from, at least from the data from the survey, the age at end depends not only on age, but also on other milestones achieved, that the patient is can self-manage the disease, that he has basically become grown up. So probably in some cases, transition at the age of 18, if the patient has grown, if he's self-sufficient, then that can be called transition. But as we saw from the results, in some cases, transition is maybe more narrowed to the matter of transfer. So to making a summary, so probably it depends from case to case and from center to center, but it's not impossible, I think, for a transition to occur at the age of 18, the end of the transition to be close to 18.
If I may also congratulate Savi on his excellent presentation, and of course, all the team who contributed towards the completion of this study. I think it is very important, first of all, to audit our practice and become aware of our care in order to ensure that we will then secure this continuum of multidisciplinary management care into adulthood. I think one of the challenges that we would have to overcome throughout Europe is the fact that different countries have different healthcare services. For example, it's easier to implement a transition protocol in a national healthcare system, and more difficult perhaps to secure such a comprehensive multidisciplinary care transfer into a private hospital setup. And also there are differences in the ways that different countries deal with certain conditions. And I believe we will have to overcome all those challenges and have a unified approach into transitioning of patients with rare diseases. I would welcome your thoughts, of course. Yeah.
Yeah, again, please help us with Q&A. Of course, I am an adult endocrinologist, and what I think is very interesting is when I was trained, we are not dealing with transition except for the last part when the pediatric endocrinologist feels the patient and the parents are ready for transfer. And then we have one combined clinic, and then, well, the next phase, it's me dealing with the patient and the parents, and I continue in the way that, well, the pediatric endocrinologist suggested that I would continue. And then, of course, things develop. But I think that was the traditional way, and that was also already good that there was like a one combined consultation. But I think there's so much more, and I really well, like the concept of prompts for transition readiness. I really like the idea of well, continued shared care in cases that are difficult, because it's so rare for me, but more common for a pediatric endocrinologist and things like that. And the same is true probably for children that have adult disease, for example, Cushing patients with small microadenomas. Well, we are more used to deal with those. But then, you, of course, you have the concept of growth.
Can
I think there's another
ask a-
question.
Yes.
Yeah,
sorry.
Violetta,
Can I
can
ask-
you deal with
yes.
it?
Yeah, can I ask Diana, does she foresee a time moment in the future when probably her daughter Carolina and herself would like to move to an adult center?
I think the most important things, of course, is the expertise in the healthcare. I mean, exactly the care of the endocrine aspects. Because in my experience, it was very, very pure in the adult center. But it's always very difficult to go to a children's hospital, because in our life, we are really trying to improve Carolina autonomy. And it's always going up and down, up and down. And as you know, with the chronic diseases, it's always like this, because if you are ill, you lost your autonomy for a while, for a week, for example, and then you have to regain it. Each time is like this. So if I could find an adult center with the proper transition program that can help us to improve her comprehension of the illness, because at this point it's very, very difficult, because I'm always looking for her, and I'm also always understanding his health conditions to prevent them. So if you have a child, this is my experience. If you want, I can tell you, when you have a child, you have a kind of symbiosis. So you understand if the child is ill, because some of these aspects are very volatile, I can say. It's very difficult to understand between epilepsy and crisis corticosurrenale, no? Maybe she doesn't understand how she feels, so she can tell me, I'm having this or I'm having that. So I have to understand for her. And so I think it's very difficult for her to become autonomous. So for me, the most important thing is a proper expertise. But probably at the time when she was an adolescent, if this aspect was taken care of together with other aspects of her development, probably it would have been much better. I don't know if
Thank you very much.
if I explain it very well.
Yes, very well. It's we're,
Okay.
how to say, we're contemporary to the increase of survival of our patients. Because when I started more than 30 years ago,
Yes.
there was no need of transition because most of our patients were not in a good state. So they stayed with us until a certain period of time and there was no such need.
Yes.
And when the process started, there was a great, how to say, lack of understanding because our adult colleagues were not used to that. But now both they and we see the need of that. So we have to develop. And I'm a bit, how to say, the audience is very quiet. I guess the audience is mostly adult endocrinologists, and I'm a bit worried about this silence. So I guess Professor Birmas will now, how to say, wake up on the audience a little bit. Okay.
Yes, well, I think we are going to go forward with the Mentimeter, but I had, as an endocrinologist, I had a question to the pediatric endocrinologist and maybe the parent. Of course, pituitary diseases deal with functional limitation on several aspects. And do you think one of the main issues with pituitary transition is the fact that there are patients with neurocognitive dysfunction, which make it more necessary to continue transition far after 18, or is that not the main factor?
I don't think these are the main patients that are creating some issues, because for these we know that care should be not discontinued. And somehow they find a way, either like Diana's daughter, to a child health center or another way. The most important issue from our point of view, the pediatric point of view, are those patients who consider them not ill, not sick already, like the pediatric patients who have been treated with growth hormone for either isolated or even combined growth hormone deficiency. They're much like the diabetes patients. You know, the studies, especially the teens study in diabetes, that found out that only about 25 to 30% of all patients are keeping their good care when they become adults, 18 years of age. They kind of escape from care. They try to be autonomous. They don't try to be sick anymore. And until they find the proper place, they're just devoid of any care. And for us, this is the major problem. We try in every possible way. And I personally believe that until we have a structured transition that is accessible and available for everyone, we will lose patients. And very unfortunately, some of them have a very severe fate. I will always remember a patient who was just turning 18 with a combined pituitary deficiency, who came to have a nice summer at the sea at our place and stopped taking her medications. She went into a very severe adrenal crisis, came to the hospital very late, and unfortunately we couldn't save her. And when I'm telling that story, it's really breaking my heart, because she was treated very well and properly since she was a baby. That's something we have to prevent for the future.
Mm-hmm. Well, thank you for sharing this. I think this also answers the question by Emily Wade about comparable structures that already exist for more prevalent diseases, for example, diabetes. I think transition is in development for all kinds of diseases, and you already compared type 1 diabetes with adrenal insufficiency and the necessity for ongoing care and control and understanding and self-management. Can you add something to that, or is it more or less what you wanted to stress? Okay, shall we continue with Mentimeter?
I think Evangelia wants to say
Oh,
something.
yeah. Oh, yes, Evangelia. Please.
Thank you. I just wanted to say I completely agree with Violetta. In my experience with pediatric patients who are being transitioned into adult care, I find that in hospitals that they have well-developed adolescent clinics, the transition of care can be better structured and better implemented because the adolescent clinics in a way facilitate the transition of patients from childhood into adulthood. And so one suggestion that I would have is to try and utilize those centers that they have well-developed adolescent clinics as centers that would also secure the multidisciplinary care transition of patients into adulthood. So this would be a way to help with our patients through adolescent clinics.
Thank you so much to all of you for this very interesting discussion. And I think that all of us should learn and should give a more thoughtful consideration when we, sometimes it's like straightforward that a patient with a rare disease treated in a pediatric care will fix an appointment and come to our clinic, but apparently the practical or daily basic way to us and the continuation of the care is much more complex. So it's really important that we have this discussion and to consider all this complexity and to try to make it better from our side.
Well, as one of the issues that I heard is that probably per country, healthcare systems are so different that's probably when addressing guidance, well, of course, there is a ESE EU way of thinking, but we also need to act nationally. Don't you think?
Yes, for sure. So the chat box also exemplifies how different and how dependent per a member state the continuation of care needs to be completely dependent on the resources available and reimbursements of growth hormone or other expensive replacement therapies. Yeah. So the Mentimeter always provides added value. So I propose, dear chairs, that we continue with the questions. Yeah. And as an example, I will go, I think that you need to provide the audience with perhaps 20 or 30 seconds to go to their web browser and to log in into the Mentimeter.
Yeah, you can use your telephone and go to www.menti.com and then fill in above at the top level of the screen the code that is mentioned here. And then the first question, it's an open question, and because the audience is probably mainly adults, but we will see. What kind of rare endocrine pituitary diseases that are usually seen in adults do you, well, consider in pediatric age? So the adults, more common in adults, things that also can occur at pediatric ages and deserve extra attention by the combined pediatric and adult endocrinologist of the center. Does it work? The isolated growth, yeah. I see the pituitary adenomas that of course are more frequent in adulthood than in pediatric care. So this is usually where the combination of neurosurgeon, endocrinologist, and pediatric endocrinologist is combined. I see the TH isolated deficiency probably here it's the other way around. So somewhat more experience in pediatric endocrinology than in adult endocrinology. Don't you think, Violetta?
Yes, exactly.
And MAN1, what would we consider here?
Usually the patients we have come through the adult clinic. When they start screening for other affected members, then we see the MEN syndromes. But sometimes it turns out at 6 years that the child has already affected thyroid, for example. So it's another good example for the collaboration between the specialties.
Yeah. Yeah, and here I think in MAN1 is also very important to don't lose those adolescent patients in the adult clinic if they forget to have their MRI scans, etc., isn't it?
I can see a primarily pediatric disease that is mentioned here, the congenital adrenal hyperplasia, which is primarily pediatric, and these are the bulk of patients that we have to transfer because they are really posing also issues in adulthood, and nobody cared about them beforehand, apart from the fertility clinics, because they have fertility issues. Now many cardiovascular metabolic health issues are already known. So this is a typical pediatric disease.
And I think also the change in dosages is so much more difficult during puberty and in the growing condition than when they're stable as an adult.
Yes. Also, the way of monitoring this, there was a nice collaborative paper from the network that found out that different metrics for the dosing of the medications is leading to similar results while the patients are well looked after. So it's really a great outcome, I think, of that study.
Yeah. Are there questions? Please add them in the Q&A box. Does anybody from the faculty want to add something here? Curious case, a remark?
I had a connection issue with the Mentimeter, but I suggested also germinomas or other rare tumors
that are more frequent in childhood, and sometimes we are encountered to them as adults. Specialist, you mean?
Yes, so we see many young adults with germinomas. I was wondering whether, to what extent they are also seen in adolescence.
I think there are, yes.
Not only in adolescents, but also in younger children. It's at any age, and the younger the patient is, the more aggressive the disease is. So it's really a challenge.
I would propose that we go to the next question. This is a yes, no. I think it's never black and white, and it really depends on the experience of the center. Of course, two doctors know more than one doctor, but on the other hand, shared care can also be complicated if you want to have a clear communication. Are there examples to mention here? Good examples, pitfalls?
I can give you an example from the clinic with a patient who has acromegaly, very rare patient, maybe one of the few I've seen during my practice, 14-year-old girl, and she has great problems with puberty also. And puberty is something that I think is mostly known to pediatric endocrinologists, and also a very demanding mother with whom only a experienced person can get into terms, because otherwise she doesn't allow anything to be done to her daughter. So this is an example I can think. I'm sure Evangelia has many other examples.
Yes, I agree that the pediatric endocrinologist would be very useful, because we are acquainted with all issues relating to growth and puberty. Cushing's disease would be another example of a rare adult endocrine disease that could be better managed by joining forces with the adult endocrinologist, and very rarely cases of hypogonadotrophic hypogonadism, not with respect to pubertal induction, but also with respect to fertility preservation. Again, would be another example that adult endocrinologists and pediatric endocrinologists could contribute jointly for the better care of the patient. Thank you.
Thank you. Let's move to the next. Well, where does the adult endocrinologist needs to take their pediatric endocrinology books and papers? And well, probably in the first question, we already had some examples of isolated growth hormone deficiencies. I think we in a center had a recent example of the IGSF1 deficiency that were really, well, of course, a joint venture between pediatric endocrinologist and adult one, the germinoma, the craniopharyngioma. Of course, craniopharyngioma, very important topic, probably topic for a future webinar, Simona, maybe. There's so much to tell about it. For example, the dietary advices, the help with growth and behavioral problems. I think everything that is growth and puberty related is not our comfort zone, and as an adult endocrinologist. Maybe most of the topics we have discussed here. Shall we proceed to the next question, or is there a comment? I don't see a comment from the audience. So we move on. Which attention needs to be given to a parent in the transition phase? Diana, are you still there?
Yes, of course. Let's see if someone writes something. That's good one. Respects over their fear for the adolescent's child. Listening. Good. Yes, this is very good. Try to keep the adherence and motivation of the child. Just me.
I see psychological support, I suppose, of the parents themselves. Is it common? Is it used? Is it necessary?
I think it depends on the person, because there are parents who oppose psychological support. They think they are strong enough throughout the process and do not want to have any outer interference, while they accept psychological support for their children and adolescents. And I think it depends on the multidisciplinary team and the knowledge of each other between the team and the patient and the family. But maybe Diana can say more on this matter, psychological support.
Yes, it's really depend on the parents of each individual. But if the psychological aspects are taken care of in the care as something, of course, it's useful. I think it's very, very important things in the pituitary condition, and to help the patient, the real patient, to understand his symptoms and his health condition, his problems, because they don't. So they don't, if they are not autonomous in the treatment, it's difficult for the parents to have them having the treatment. What one of the things, but I think all these answers are interesting.
Yeah, thank you so much. Let's go on. Do we have unmet needs about information, about knowledge, about communication? Please give your input. How to empower children. Well, that's not what we learn at internal medicine training. On the other hand, we learn to empower adults. But is it something different? I think so, yes.
It could be different because children are very, very good at emotional and social cues. You don't need to talk much in order to make the connection. And it's always different with different family, different child. So you have to be very sensitive on the response. And I think it takes a lot from our time.
Yeah. I agree fully of being not well equipped to find the roots in case there are learning disabilities, and I don't have the multidisciplinary team equipped to communicate with schools and trainings, etc., etc. Is that a issue that is, Savi, was that in the questionnaire as well?
It was not specifically asked what adult endocrinologists think is unmet need, but unmet needs were asked in general. For sure, from my personal experience, there are a lot of things that are untypical for adult endocrinologists when dealing with growing adolescents and parents, but this is definitely a question that needs more detailed answer.
Yeah. Well, I think we get great input. Thank you so much. Well, it's 6 o'clock. I'm afraid we need to conclude. We had 3 other Mentimeter questions prepared, but I think we can do without. Well, I would like to thank the faculty. I also would like to thank the ESE team for help preparation this great program. Thank you so much for attending. Thank you also for your input. Please, if there are any thoughts later on, be welcome to share them in a later stage. The idea is that this will be an ongoing program with more than 1 session. So the next joint webinar will be at somewhere in autumn 2022. Date will be communicated later, and that will be about the holistic approach to the treatment and surveillance of MEN1 patients and their families. I have one eye to the faculty. Is there somebody who wants to add? Otherwise, I would like to conclude and end this webinar.
Thank you very much.
Thank you.
Bye-bye. Have a nice evening, everyone. Thank you.
Goodbye.
Thank you all, and compliments to all. I'm very proud of both the audience and the faculty. Take good care, dear friends. That's most important.
Thank you.
Thank you.
Bye
Thank you
bye.
very much. Goodbye.
Bye bye.